Thank you so much for everyone joining us today. My name is Amy Janke, and I am the chair of the Department of Behavioral and Social Sciences at University of the Sciences. I want to welcome you all to the 11th annual and first virtual Lois K. Cohen Lecture in Global Health. We're delighted you could join us here today. This ongoing lecture series is brought to you through the generosity of our alumna, Dr. Eileen Warner-Marin. Dr. Warner-Marin graduated in 2007 from the University of the Sciences with a PhD in health policy. She is here, I believe, in the audience with us today, and we are very thankful for her support. This lecture series is in honor of her aunt, Dr. Lois Cohen, who's here with me and will help lead our virtual fireside chat at the end of this presentation. Dr. Cohen is a native Philadelphian. She was educated at the Philadelphia High School for Girls and the University of Pennsylvania. Dr. Cohen then earned her MS and PhD degrees in sociology at Purdue University. After serving as a visiting lecturer in the Department of Sociology and Anthropology at Howard University, Dr. Cohen began her federal government career as a research sociologist in the Division of Dental Health. She co-directed the World Health Organization International Collaborative Study of Dental Manpower Systems and was also involved in facilitating the design and conduct of the WHO study of oral health outcomes. Dr. Cohen currently serves on various organizational boards and regularly serves as an expert consultant to the WHO in Geneva and its regional offices in the Americas. This year, we are honoring Dr. Cohen with an outstanding lecture by Dr. David Rubin. As director of PolicyLab at Children's Hospital of Philadelphia and a professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania, Dr. Rubin is responsible for a center of emphasis that includes 35 faculty and instructors and more than 60 staff conducting population health and community partnered research. With a content focus on developing health system and public program innovation to meet the needs of high-risk children, he also serves as Director of Population Health Innovation at Children's Hospital of Philadelphia, supervising a team that develops and implements integrated solutions using clinical care and technology to more proactively identify and provide needed services to at-risk patients across primary and subspecialty care settings. To date, he has authored more than 120 manuscripts spanning peer-reviewed research, policy analyses, and edited chapters in prominent pediatric texts, including seminal manuscripts in JAMA, Health Affairs, and Pediatrics on quality of healthcare coverage and access for children in low-income families, and the delivery system interventions that can return value for public health programs. He is particularly drawn to the challenges of meeting the needs of patients receiving publicly funded health insurance through programs like Medicaid and CHIP. He has made numerous presentations to the medical profession and to the city, state, and national leaders, including the U.S. House of Representatives and the U.S. Senate, to guide evidence-informed health policy decisions on behalf of children across the country. Dr. Rubin is one of the lead investigators on PolicyLab's COVID-19 forecasting model, known as COVIDLab, Mapping COVID-19 in Your Community, which tracked coronavirus transmission and test positivity rates across all US counties and provided 4-week case incident forecasts for more than 800 counties with active outbreaks between April 2020 and May 2021. Dr. Rubin and his collaborators received national attention for this unique project, which they used to advise the White House Coronavirus Task Force, governors, state public health officials, and Philadelphia leaders on emerging hotspots and local strategies for reducing the spread of the virus. The modeling project also informed PolicyLab's school reopening guidance and guidance for in-person schooling, for which Dr. Rubin is a lead author, and that leaders from school districts throughout the country have cited as informing their COVID-19 safety plans. And certainly that parents in many school districts, I think, have also appreciated. At the University of Pennsylvania, Dr. Rubin is a senior fellow at the Leonard Davis Institute of Health Economics and a former associate program director of the Robert Wood Johnson Clinical Scholars Program. Externally, he is a past member of the American Academy of Pediatrics Task Force on Foster Care and the Committee for Early Education, Adoption, and Dependent Care. Based on the large body of this work, he was appointed in 2013 by the President to the White House Commission to Eliminate Child Abuse and Neglect Fatalities, which was tasked for recommending a national strategy to prevent child abuse fatalities. He is also a past member of the Pentagon's Military Family Readiness Council, which is tasked with strengthening programs for families across armed services. Dr. Rubin is a practicing primary care pediatrician at Children's Hospital of Philadelphia. He holds a bachelor's degree from the University of Pennsylvania, an MD from the University of California, San Francisco, and a master's degree in clinical epidemiology and biostatistics from the University of Pennsylvania. He also completed a residency in pediatrics and a fellowship in child maltreatment at Children's Hospital of Philadelphia. We're incredibly honored that you've agreed to speak with us today and excited to hear you speak on predicting the pandemic from science to policy. Now, before I turn over the virtual lectern, I want to do a bit of housekeeping. So following the presentation, there will be a fireside chat between you, our virtual audience, and our distinguished guests, and our namesake, Dr. Lois Cohen. I will help moderate the chat using our virtual Q&A features. I would also like to acknowledge the hard work and effort put forth by Melody Taylor, Christine Adonanzio, and Michelle Albert, whose tireless efforts certainly contributed to this program and truly brought it to life for us. Now, without further ado, I'm pleased to give the virtual lectern over to our distinguished guest, Dr. David Rubin.
Well, thanks for having me. That was a great introduction. I was like, do I know that guy? I just want to thank you for having me. I'm going to give you a peek into the sort of strategy for a team now that has grown to well over 20 folks at Children's Hospital that started out actually in March of 2020 when COVID started to become a reality for all of us. We were able to leverage a lot of experience, mine with regards to population health science and a lot of work on local area variation, some of our biostatistical faculty who had experience in longitudinal analysis and predictive modeling, as well as a host of other infectious disease epidemiologists and colleagues at CHOP to put together the COVID-19 Lab. I still believe to this day, I think we started that journey out because of our concern that when the pandemic started back in March of 2020, if you remember, everything was about New York City or the national models that were going to tell us how many people were going to die. But if you lived in Harrisburg, Pennsylvania, or you lived in New Orleans, Louisiana, or you lived in Philadelphia, for example, it was very hard to know when would concerns arise in my neighborhood. And my entire experience with children and families had been sort of demonstrating models around how services and the experience of families really vary at the local level. And we know for certain that in terms of schools and in determining school policy, everything is local, even within a community, from public schools to private schools, et cetera. And so thus was born the COVID-19 Lab. And I'm going to take you on a little bit of journey on how we've made decisions and what our team has learned about the applied public health model. I think we learn a lot about public health and how they make decisions. But if there's one thing to take away from this lecture, it's that applied public health is informed by the science. But sometimes the decisions that politically are made are more complicated than just the science, and they balance public opinion, the appetite for risk by communities. Obviously economics and competing risks for kids that might even include sort of mental health issues and interruptions in schooling and social isolation, and how that all comes together to try to inform strategies that I think represent the middle and not the extremes of what we've witnessed throughout the country. So with that, let's dive right in. So for those of you not familiar with PolicyLab, our team has always had this, what we call an evidence to action model. We anticipate, some of the challenges that children and families are experiencing, and we try to perform what we call solution-oriented research. We identify the problems that may be resonating. We often do this by engaging stakeholders early on to develop our research around questions that are of interest to them. We perform those research studies, in this case, our predictive modeling, and then we have a whole communications and policy strategy to make sure that the information that we are finding is actually handed into to the people who can most use it. And we don't judge people's decisions on how they use the data. We value that they make decisions informed by the data, and I think that's an important distinction, because once you start sort of judging the decisions of policymakers, you can often find yourself, to me, what's important is that people make decisions informed by evidence and not simply force your own opinions onto them. And so whenever we're actually working with policymakers, regardless of left or right, independent, conservative, liberal, we often present a menu of options and we explain the background behind that, but we don't prejudge their choices. And I think that's really important. This team is not just about me and the work that I've done around local area variation. Like I said, it's an interdisciplinary team that's made up of a really talented team from Penn and CHOP. You're looking at Dr. Jing Wang, who's our lead biostatistician, who's an absolute superstar, really interesting personal history. She went to Wuhan University, had friends and family in Wuhan. And so this has been very personally motivating, her journey to develop what I still think is the best model out there in terms of predictive modeling for the pandemic at the local level in the United States. You're looking at Brian Fisher and Susan Coffin are two of our infectious disease epidemiologists. Dr. Susan Coffin has a role with the Philadelphia Department of Public Health as well, and Dr. Meredith Matone, who informed our school policy, is a doctor of public health who trained at Hopkins and is our scientific director at PolicyLab. So here were the key questions. When we started out this pandemic, there have been some questions that really have persisted over time. Number one is, how much do children contribute to community transmission? And if you remember early on, there was a lot of hypotheses that maybe children don't contribute to transmission. It's all about the adults. I call that the wishful thinking, our own biases. We'd all like to believe that children have no part in this. And certainly they have less severe disease than adults on average. But they're clearly vectors. And I think as we've gone through the pandemic, we've recognized that the early experience with children in the pandemic, they were sheltered the most quickly. And so therefore their infection rates did not build as quickly. But once they were infected, and we saw this early in our practices, their risk of transmitting it to adults and other vulnerable members of the community, whether staff in the schools or parents and grandparents, or just people in the market, was just as high as it would be for an adult. Can multi-layered safety protocols reduce in-school transmission? How could we use an applied public health model with multiple layers to get kids back for in-person education, and would it work? Well, we now know that it works extremely well and has continued to work despite the changing genomic background of the coronavirus in terms of moving from alpha all the way to delta and now these new strains. The same things have worked consistently across time, and we'll review some of those mitigation strategies. And then the question was, how much could you reduce secondary transmission, what we call the secondary attack rate? And we'll talk about the data that we're revealing now and how it's allowing us now to take the next step beyond mandatory quarantine for children who are exposed to coronavirus in school. And then the million-dollar question right now is, when can we pull back? When can we get back to our lives? And we'll talk about that at the end. So one thing that's important about our model that distinguishes it from nearly every model that's out there to date is that we incorporate weather. COVID seasonality is often unrecognized and underappreciated. Certainly, we've seen significant amounts of transmission in hot, humid environments through the summer, and that's led people to think that maybe there is no seasonality to this virus. The dynamics of transmission, however, are complicated, is what I would say. But one of the strongest and most influential forces over time in a multifactorial process is that weather is important. But it's not linear. It's not an either or. It's not a binary. What happens is that you see the least transmission of coronavirus in the spring and fall, or during the more temperate months, when there are fewer gatherings around holidays, when people spend more time outdoors, and when people are in their routines and they're not traveling as much. At the very high temps, as denoted here, which is the nonlinear association of what we call wet bulb temperature, which includes humidity and ambient temperature, and transmission across 211 counties that were reported in the JEMA network last year. You can see there is elevated transmission compared to 10 degrees Celsius, which is the reference temperature in this figure. 10 is about 50 to 60 degrees. But when you get up to 70, 80 degrees, you start to see elevated transmission. Partly it's because people gather more. I think a lot of what you see at the higher temperatures is gathering behavior. When it gets extremely hot, I can tell you that if I were to reproduce this curve today, this bend downwards at the very high temperatures was just a reflection of very little data back in July of 2020 in terms of of what we might see as we got into the really high temperatures like Arizona saw, or Florida or southern Texas, for example. We know this continues to go up. And so you kind of end up with a twofold increased risk of transmission compared to spring and fall in the hot weather months. On average, controlling for mobility in terms of how people are moving or traveling, controlling for how densely crowded their cities are, the ethnic composition of their cities, a whole host of factors that we control for, to kind of isolate out this weather effect. But if you look out on the left-hand side of this curve, you see what I call the pure effect of the virus, which is its proclivity to spread in colder temperatures. And so, it's, again, what's occurring in lower temperatures, if you remember early in the pandemic, the poultry farms were the first ones, the poultry farms and meat industry were the first industrial locations that very quickly got subsumed by the coronavirus pandemic. And what was unique about those settings? Well, there were congregate care settings of more migrant workers. That was an important contribution, but it's those cold freezers. And that was a very clear signal that temperature was playing an effect. And other respiratory viruses spread more easily in colder temperatures because they're more in colder, drier temperatures, and certainly indoors, the virus will suspend in the air longer. It will spread over longer distances to the degree that that SARS-CoV-2 or the coronavirus, as people know it, aerosolizes and spreads over longer distances. It's going to do it more in colder temperatures. It's also why on school buses during the fall and winter, that is a very difficult location for schools in terms of the risk of significant transmission in those settings. And so what you have in these lower temperatures is a higher proclivity of that virus to spread, higher inoculums, people moving indoors and gathering in indoor settings. And then you have the holiday gatherings themselves, and that leads to a fair amount of transmission. And if you look at the United States epidemic curve, most of our deaths occurred last winter. Probably over 400,000 of the 700,000 plus deaths occurred between November and the end of February last year. And so as we look forward and we peer forward to hope that the pandemic is coming to end, take a look at this curve and what it might remind you. We're being deceived right now by numbers that are falling nationally after the summer wave, when I can tell you right now what we see in our models is that the upper Midwest, Alaska, New Hampshire, Maine are already demonstrating the left-hand side of this curve. And so we still have another round of this. How significant that wave will be is complicated because of the many factors that impact transmission. An important thing that we had to learn early on as we tried to combine our models, what our models were telling us with how we might inform school policy or mitigation strategies for governors, is that this was a novel coronavirus. And John Maynard Keynes once said, "When the facts change, I change my mind. What do you do?" And I think that the American public has been pretty hard on a lot of public health leaders throughout the pandemic when they have changed their mind. I've never seen that as a bad thing. I've seen that as our public officials adapting to the new knowledge that was on the ground. There were times that we had to do that. Were there things that we might have done differently in retrospect? Yes. For example, I think I might have gotten kids back to school more quickly if we knew how well those safety protocols would have worked. But we were sort of playing Russian roulette because we had an entirely unvaccinated public at the time. And what we know now, if we were informed by the knowledge now, certainly we would have opened schools earlier to start with. But I think, with a very anxious public, with the magnitude of risk of what it was, we went incrementally and we went more slowly. So let's talk about that COVID lab. And so if you go onto our PolicyLab webpage, you'll see that the projections. We actually project every week 4 weeks forward. What we think is likely, it's a forecast, the magnitude of transmission that a county is likely to see. And for most of the pandemic, we were modeling about 820 counties across the United States, which represented well over 80% of the US population. We had to have counties that had some transmission in order to include them in the model. But we picked up, we had all 50 states represented, in Washington, D.C., and we had state capitals. So we even had rural states. So we had a really good geographic spread of counties, and you can really see the regional variation when you do these models week to week. I've gotten much quicker about doing them. I used to spend good 10, 12 hours. I read every single model, and you can kind of feel the movement of the virus across communities and across time. As opposed to what virologists do in terms of just talking about the R naught, which is the number of people infected for every given infected individual. The R naught is sort of a scientific property that's defined in a virus. For example, the Delta virus is felt to have a much higher R naught than the original strain of SARS-CoV-2, and certainly the Alpha strain that came from the UK earlier in the year. And that may be true. And I think the biologic, that over time, the adaptation of virus to try to continue to propagate will favor the selection of more contagious strains. And so the higher the R naught, the more contagious the strain is going to be. But our model actually sees the community level transmission as more complicated than the innate properties of the virus. And this, to me, is what makes our model not just unique for its local area variation, but because it assumes that the R naught is really only one of many factors contributing to community transmission. What matters equally is the weather, like we talked about, but how people move. You can't spread the virus unless you put two people in the room together or put more people in the room together. And sometimes I think we give Delta too much credit when in fact we can't really compare across time the impact of Delta now or what Delta might have looked like back a year ago when we were all wearing masks and barely going out in public. And that's important. It also, when we think of this as just Delta is more contagious, or this new AY subvariant from England is even more contagious, it sort of leaves us as defenseless. Like we don't have that we are unable to control this ourselves. When in fact, mobility and how people travel and move and gather, which all factors which have been included in our model over time, those things are likely more important than the actual properties of the virus themselves, and certainly the mitigation strategies themselves, whether there are masking policies, right? Whether there are occupancy restrictions. All these things select out for how transmission is to occur. Some of it we can observe. We can observe through some of the cell phone data how people go to retail locations and restaurants over time. We cannot observe how people gather in their homes. We can observe how people travel across county based on cell phone data. But there are lots of things we can observe, and what we ended up doing was building what's called a random effects model, that a lot of the unobserved confounding or unobserved variables are likely picked up in the way a county grows over time or declines over time in transmission compared to other counties in their regions or other counties in other states. And so we let each county grow at its own rate of speed based on its own experience, which is another way to kind of pick up some of the unobservables. But we include the mobility factors, we include weather, we include time in our model, we include vaccination coverage, we include some measures of population immunity as well too in terms of cumulative incidence, and all that together alongside a really strong recurrent validation of our models has allowed us to put our best estimates on these forecasts. Now, when you go and read our forecasts, and they're posted again today, they were re-up today, I always let folks know there's always uncertainty in these forecasts. And the way I've learned to read these forecasts over time is you never take one forecast and take it and overemphasize the output of one forecast, because there's a fair amount of uncertainty. And so what you're looking at here is Philadelphia from last summer, right before schools reopen, and we'll talk about how this informed our decisions in terms of early school openings in the Philadelphia region last year. What you can do, though, is take a look at Philadelphia's forecast week over week. And if multiple weeks, the slope of this dotted line that you see on the right is getting steeper, you know things are likely increasing. And so the probability that that's happening by chance goes down if you have multiple weeks where you have an increasing forecast. Now, if Delaware County and Montgomery County and Chester County and Bucks County look exactly the same, which they often do when as Philadelphia moves, so goes the collar counties, as does Camden moves across the river. When you see them all marching in the same direction, that's a pretty hot signal as to what's going to happen within a region. When there's variation in that signal, it's a little bit unstable. And we're in a period now where we have some uncertainty about which way we're going to go in our own region. But you can see these trends developing over time. You can triangulate them against emergency department visits and hospitalizations. And one of the factors we include in our model, which is the proportion of PCR tests that are positive in any given week. And as you know, that PCR test positivity has actually been one of the best leading indicators of any we include in our model. And so last summer, as we dive into school policy, now we're giving you a little bit background on our model. You can take a look at the dark blue here are the actual case incidents, and we're modeling what's called the instantaneous reproduction number, which is a measure of the reproduction number on any given day, and then we're projecting it forward, as opposed to modeling with a time invariant R naught like we talked about before. Now, what you can see here is it's very clear, even without knowing the components of the model, that something changed after July 4th last year. Last summer, we started to build, and we were clearly building as Labor Day was coming. There was no doubt about it. The entire Northeast was building already. Out in the upper Midwest, in Wisconsin and Illinois and Minnesota, they were seeing substantial transmission. And we knew everyone was coming back from summer holidays to just launch school. We made the decision at that time, based on the data that we were seeing in our models, to recommend a pause and go virtual for the first couple of weeks of school. Now, that was not a popular opinion. There were a lot of folks who just wanted to jump right back into school. Our kids had been out in the spring. We knew, based on our understanding of weather, that by late September and early October, another window would open, and that window opened. And most schools in our region opened virtually to begin the school year. We will not know how much that saved us from some of the rates that were seen in the upper Midwest. I can tell you that we saw about a third the level of transmission. Philadelphia has outperformed other regions of the country, and we didn't really explode until after Halloween and certainly around Thanksgiving and Christmas, whereas the upper Midwest was in trouble by mid-October. I think in retrospect, we know now that our protocols, the mitigation protocols I'll review in just a moment, we know now that we could have probably opened up even with this level of transmission. We've certainly seen much higher levels of transmission in the Philadelphia region with schools open. But at that time, we were acting conservatively. We were concerned about the risk of significant rises in September and October. I think the one thing that really could have changed the way we viewed the September timeframe last year was the availability of tests. We now have a program in the Southeast region with rapid testing in schools. And had we had testing in the schools at that time, we could have added an additional layer of safety and assurance that people who were infected with COVID in their communities were not just introducing them into those infections into school environments. We've already performed now well over 600,000 rapid tests in the Southeast region. We're probably one of the largest school-based testing programs in the country. And I regret we didn't have that testing program last fall, because that could allow us to really jump out of the gate, even with some of the pressure we were seeing. Next major decision. So we started to get schools open by late September, early October. Schools started getting their returning for in-school education. Now, our team knew, based on our modeling, that the winter was going to be bad. We just didn't know when it was going to hit. And if you can remember last year, it was Halloween. We were looking at Thanksgiving and Christmas, and we overlooked the contribution of Halloween and the transmission that occurred between and among children and families that really, it blew in like a hurricane right after Halloween. And what you're seeing here is some of our other data that we reviewed. These are the actual instantaneous R's that were observed in the Philadelphia area starting in September. And you can see how we had dropped and stayed pretty low below 1 for most of September. Had bumped up fairly quickly as schools started to open in the end of September, but then kind of had stabilized, but then slowly kept building until about a week and a half before Thanksgiving. We were looking at R's well over 1.5, which is substantial growth. And as you start to double, it starts to compound. You go from 100 to 200 cases to 400 cases to 800 cases. We were in bad straits. We had hospitals beginning to divert in Delaware County and Montgomery County. The city capacity in the city was good at that point, and yet our public health authorities at that point were fatigued. They were under assault in the media and publicly for the mitigation strategies that had continued from February and March. And we had a public that was fatigued. And sometimes you had to take an unpopular opinion. And the most unpopular thing I did at that point, because public health was not reacting and we were 2 weeks out from Thanksgiving, was to go to the Philadelphia Inquirer and warn the region that we were about to have unprecedented transmission at the Thanksgiving table if we did not try to perform or at least recommend a collective quarantine in advance of the holiday, so that whether you were at work or whether you were at school, everyone needed to join a collective quarantine. Now, that was really a turning point for me personally. My family got personal threats as the result of that Philadelphia Inquirer article. What I said to the reporter at the time, people were very anxious at that time. People could see the numbers rising and the hospitalization rates rising in the region. What I said to the reporter was that we are going to have a catastrophic situation if we do not change, if we do not pivot right now in advance of the holiday. Waiting for the holiday to go by, you've lost your moment. This is the moment. And I said, if we don't, hospitals will be overrun. The article headline was, "We are in a catastrophic situation, hospitals are overrun." Now, that's not what I said, but I did use the words. And I honestly, now looking back, will tell you that's probably the most impactful moment I've had in the pandemic. It was the most stressful and anxiety-provoking time that I've had throughout the pandemic. But look what happened after the Philly.com article came out. First of all, I immediately got a call from the governor's office because they had been unsure of what their response was going to be around schools, around masking, around bars for the holiday season, around their entire strategy. They reacted very quickly after that Philadelphia Inquirer article. They saw that article. A week goes by, the Philadelphia Department of Public Health announced its new restrictions. It kind of expedited the region starting to move. But the most important thing is, I think that the residents of the Philadelphia region, as angry as they were at me for recommending that kids stay home from school the 2 weeks before Thanksgiving, the R's started coming down. People stopped gathering. They put on their masks. They could sense that something was in the air. And by the time we hit Thanksgiving, the R's were below 1, indicating declining rates of transmission. So that once we hit the Thanksgiving table, it bumped. And it did bump after Christmas as well, too, as you can see later in towards January. But the rates were far lower than other regions of the country. I think if I look back and when I look back and it's all said and done, this pandemic is over, this was the time I saved the most lives, because between, like I said, in late fall and early winter and into late winter, we lost most of the folks to coronavirus in terms of deaths across the country. And so this was the time of the major impacts, and we were able to blunt those impacts with some of the the decisions that I think a lot of community members made on the basis of a lot of that, of a lot of our, not just ours, but at least that had been initiated by our recommendations at that moment. So, when schools started reopening after the holidays, because I think the race to reopen schools in full really started after January. Once those gatherings were over, once days started getting longer again, the weather started to warm a little bit, rates started to fall. And you can see this is an example here of rates beginning to fall here into 2021, into December, and then into January. As rates started to go down, the race was on to get kids back into school with these plans. And we created our dashboards in a way that any school administrator around the country could look at the two most important things to inform their strategy, which was the test positivity in their region and their weekly case incidents, which was pegged to what the CDC was coming out with their own guidance. When you looked across, we also included over time really important data on ICU bed capacity, because as we turned the year into 2021, I think it became very clear that once people started to be offered vaccinations, the only reason why you would pull back at that point was really if hospital bed capacity was really becoming an issue. In some places it did, like in this summer in Florida and Louisiana, it really became a problem. Louisiana chose to reinstate a mask mandate, which really help them blunt what was occurring in Louisiana. Florida decided to push through, but their excess deaths were far surpassed any other region of the country. So let's get into those CDC guidelines. So as we got kids back to school in full, these were the key guidelines that were in place last year. The universal and correct use of masks. We have an article coming out demonstrating the value of masks at the community level. But the masks have been the easiest and the most impactful of strategies, and particularly indoors, to reduce the spread of COVID between children. Physical distancing helped a lot. And that's why we had those hybrid plans last year. But in an effort to get kids back to school in full, we had to abandon physical distancing by spring of last year, particularly in our region, and certainly this year in most of our schools. Hand washing and respiratory etiquette, keeping sick kids out of school. Some cleaning and maintaining healthy facilities. I left out simple solutions around ventilation and air exchange. And then contact tracing in combination with isolation and quarantine in the work with our health departments. This is what we had last year, but as we return this year, even though we're abandoning physical distancing this year, we have so much stronger layers of that are now supporting the resumption of normal school. Not forever, but at least during a period where we still have a group of younger children, the 5 to 11-year-olds and even younger, who've not yet been offered vaccination. And the number one intervention that we waited for till December last year is vaccination. No matter how we have sliced vaccination coverage is the number one mitigation strategy for reducing transmission, severe disease, and deaths across communities. Indoor masking during periods of substantial transmission. We have our paper in Health Affairs is likely to come out in the next few weeks, demonstrating about a 20 to 30% reduction that tapers over time, but can be really impactful during periods of surging transmission. And then testing to identify individuals with SARS-CoV-2 to limit transmission and outbreaks. These are three key pillars of the response this year. Now, we understand that you need to weigh trade-offs around local decision-making. Our team, if you look at our school guidance this year, we never changed our school guidance, after the CDC changed theirs and the AAP changed their own guidance. We had believed that, we had learned through advising myself, well over probably 500-600 schools locally, both public and independent schools around the region, plus several hundred independent schools around the country, how important it was for local areas to make their own decisions. If you were a high school that was fully vaccinated coming into this year, who had lots of testing available and your staff was vaccinated, a lot of those schools wanted to go mask optional. Other schools were in areas with poor vaccination coverage, and they were returning for the first time, and they were not equipped or able to do the kind of testing that some other schools were able to do, and they really needed to require indoor masking. So we were not surprised to see our largest city school districts all return with masking. But a debate ensued here, which is, at what point do we start to weigh the trade-offs on the right of mental health issues developing in kids in terms of getting kids back the risks of prolonged masking, particularly in younger children who require a lot of facial cues in terms of learning and socialization, the distraction from education that a lot of whether testing or enforcement of masking was causing, and then prolonged periods of social isolation because of disruption of extracurricular activities. Now, we had to shoulder that burden last year because we had a completely unvaccinated public, and the risk to the public was so high from transmission. We had to do whatever we could to buy time for vaccination and minimize transmission, right? But I would argue, once adults were offered vaccination, this right side is starting to tip heavier. And we need to start recognizing that the danger we're facing now is that even though we're seeing new variants and we're continuing to see transmission, the protection against severe disease has been really strong with all the vaccines. And even more so now that some vulnerable members of the community are being offered boosters as well for those who choose to get them. As that occurs, I think the consideration now is really more tipped to trying to err back towards normal. And I'm getting lots of questions now. When do the masks come off? How do we get back to mask optional policies? When can we stop testing? And I can tell you it's coming. I think we've never weighed in to say you must do it here or then. We've always talked about local flexibility. The other thing we've said, is you have to be responsive to your health department. And right now we're under a state order for masking, and that trumps whatever I might think about local masking policy. But once those state orders are lifted, I do believe it's okay to give local schools the ability to make their decisions about whether they want to flex to mask optional policies. What I will tell you is that the overwhelming majority of schools arrived at the consensus that we should play it safe, at least until the younger kids have been offered vaccination, as an issue of equity. And I think that makes sense. And buying time to get there, and that'll start probably in the next couple of weeks, it gives you a sense between the winter holidays coming and with the vaccines now rolling out for younger children, we're likely to see a period in late winter and early spring where we're going to see a lot of these restrictions really roll back, even if we're continuing to see some transmission. Now, some people will caution me and say, but what about what just happened, which is the rise in pediatric hospitalizations that was reported over the summer? This was a really challenging time for us. Right now you're seeing about over a quarter of all new infections in the country are occurring among children. That's because they've joined the unmasked in our communities. They are at our parties. The genie's out of the bottle at this point for the kids. And so you saw rising hospitalizations through the summer to a tune of about 1,600 kids in the hospital at one point. But the media would report every child in the ICU or dying on a ventilator. And it made it very difficult to advise schools and advise communities as the fall came around, because we now have two camps on the extremes. We have those who would prefer nothing and have preferred that from early on in the pandemic. And you have others who are now fearful of even rolling back any restrictions. I will tell you that the risk of severe disease, regardless of the variant, has been about the same for kids throughout the pandemic. It's just that more kids have been getting COVID since the summer. The overall risk of death, for example, for children is less than 1 in 100,000. Through most of the summer, we never exceeded a dozen kids in the Children's Hospital of Philadelphia, and largely because of a lot of the safety measures that our schools and extracurricular activities and camps have been doing throughout the pandemic. So, I find myself now spending just as much time trying to tell school communities who want to get back to normal quickly to try to help advise them how to do that, and also help people understand that these mitigation measures are not permanent. I spend just as much time, and I think we're going to have a hard challenge persuading those people who are now fearful to leave their homes. And I think we have to start talking about that. And I worry more about those people now than I do about the people who want to go to more mask optional policies. So the CDC is already moving in that direction. They've already laid out transmission levels, and most of the countries in that red high transmission level now. but we're going to see a lot of areas, and particularly in the South already, moving into yellow and orange. And those areas are going to be have or will be continuing to roll back mask requirements. And I think moving towards mask optional policies and less restrictions in the classroom is coming probably by January, February in our region. So here were the pragmatic schools. The schools that did it best across time, whether independent or public schools, were those that recognized that this was a fluid situation. They communicated extremely well with their parents, and they laid out the plan so it was very transparent for their families to understand how decisions would be made. The schools would recognize there's a difference between substantial transmission and moderate or minimal transmission. And so, before the state required masking in all schools, some of the best plans that I saw this year recognized that if we were in substantial transmission, they would require indoor masking. But as soon as we dropped out of substantial, they would go into mask optional policies. And I think, those kind of flexible strategies have allowed a lot of schools really to kind of be able to provide the level of protection they needed during periods of substantial transmission, but the level of flexibility and less disruption they needed when transmission was actually going down. A lot of schools have begun to factor in vaccination coverage, incentivizing school communities of the benefits of full vaccination coverage to reducing requirements for masks or for other distancing strategies that might still be in place. A lot of our schools are now testing, and we've seen a lot of interest now in testing. It's particularly around symptomatic testing, because there are lots of other colds out there as well too, but also to help kids get back from quarantine more quickly. We're initiating what's called a test to stay program in our region, which we spoke about this summer, and now the CDC is moving towards probably endorsing in the next few weeks. Where we're instead of quarantining children, we're allowing those families who wish their kids to remain in school to have them remain in school as long as they're asymptomatic, and if they agree to a couple tests during the week to assure that they're not contributing to transmission following an exposure to SARS-CoV-2. I see that as a temporary bridge until we get to a point where we just do kind of modified quarantines where exposed kids might be wearing masks for a week. I think it's really important that the schools that have done this well need to define beginning and end points for masking and other requirements. And that's why sort of varying the decisions by the level of transmission is important. And I think we would have done better, for example, with the school masking policies if we had messaged how long or what the endpoints were going to be around masking in the schools, because it feels indefinite, and it's created a concern that a lot of these restrictions will not be removed, when in fact they need to be removed, and we need to go back to normal, and we need to always right size the amount of intervention of a government in the lives of families and children who are attending school. Yes, we need to promote safety, but we need to also recognize that we need to have a fair assessment of when it's appropriate and when it's not appropriate. And be patient to ensure that all who want access to vaccination have had the opportunity to receive it. That is a consensus that school communities reach, not our center, because we met with all of them. And I think that if we polled the public, I think most people in the public would agree that regardless of where you sit on restrictions or not, that most people would agree that there's a sense of fairness in allowing the elementary school kids and even younger kids to have access to vaccination. So we've learned that, everything is local. I advise schools. I have schools that are mask optional. I have schools that are requiring everything. And I don't judge any of them, like I said. And I try to understand what their pressure points are in these complicated decisions and in applied public health models. I try to help them avoid the pitfalls of confirmation bias. Last November, when I advised that 2-week pause around Thanksgiving, all the media jumped in to talk about how kids weren't transmitting the virus and they needed to be in-person education. That was the wrong time for that discussion, and it was flatly wrong. And I think that comes from this innate, we wanted our kids to be back in school. And so sometimes you can reach judgments based on confirmation bias. You confirm what you want to believe. And you have to really avoid that when you're trying to make decisions that are really complicated with regards to safety and some of the competing risks to children. Resist anecdotes, the child dying in the ICU. That's, it pulls on our hearts, but often it will lead us to overreact. And so you really need to understand the entirety of the data. Do not become a prisoner to speculation, as we're going to start talking about another variant coming out of the UK right now. We used to call them the scariants. Ultimately, what matters is what's happening on the ground. How many people are getting hospitalized? How many people are getting severe illness? And we need to react to the actual data and to recognize that what matters more is probably how we're moving and our own routines than the actual virus itself at this point. And then be willing to compromise, understand people's points of view, not judge their point of views, but to try to arrive at some applied public health solutions that are not perfect, but are able to kind of bridge communities, which have become very divided. So I'm gonna stop there, allow you guys to ask some questions, and open it up, and I can share you some of the outtakes, and no questions off limits.
Fantastic. Well, thank you for that. We already have some questions coming into the chat, and I'll start by noting some of the comments that were in the chat while you were speaking, so focusing on how some of this data was new to folks, that they had no idea this level of research-based projection was being done at this level. And I think it dovetails nicely with your comment that, everything is local. And even though while we're in this global pandemic, this local behavior, this local data really interfaces globally in these really interesting and important ways that we need to understand to be able to act and inform policy. So I have a few questions. Lois, do you have any you'd like to start with, or should I just start with the ones that are coming into the chat?
Sorry, I muted myself. Thank you so much, David. That was really enlightening. And, we use this term, local is global and global is local, and some people call it glocal. I was just wondering to what extent there are models in the global arena that you drew some inspiration from, or the applicability of your model to the global context?
Yeah, we worked with a researcher, particularly around weather-related modeling. One of the reasons why I love our model is I said is the way we use nonlinear models with regards to weather. We're using the most sophisticated weather-related modeling brought to us by Antonio Gasparini at the London School of Tropical Hygiene and Medicine, who's done a lot of work on the impacts of weather on health and in the global health community. And we're fortunate, the water cooler, to the virtual water cooler talk in March 2020 included a urologist at CHOP who does research on the impact of weather on kidney stone formation in kids. And so he had a relationship with Antonio Gasparini, and Antonio joined us for that first paper in JAMA. And I think, he uses a particular type of modeling around weather. You should go back and look at some of the appendices from that article to see how sophisticated and multidimensional they are in terms of how we lag weather, in terms of impacts on health and transmission. Most people, even those who use weather in their models today, are using linear terms. They're using very non-sophisticated approaches. There is a very clear impact of ambient weather and humidity on transmission. And so that comes from the work of Antonio Gasparini. Now, the other thing is the model itself for instantaneous reproduction number was based on the modeling of the Ebola outbreak. The idea that, the epidemiologist sees the reproduction number or the transmissibility of a virus as a time varying construct is what differs from the virology community that sees the R naught as the property of the virus, right? And so that comes from the global health and epidemiology perspective as well.
Thank you. That opens up a lot, particularly related to climate change and health, and what they're predicting now for the United States in terms of the northern states being much colder and then the rest of us below a certain line being warmer this winter.
Yeah, these climate models and their impacts to health are going to be very important for climate change. I really do believe that there's, one of the ability to use these models, not just for pandemic outbreaks, but for also other impacts of weather on health and the lagged effects of weather on health are going to be really important.
And this relates to one of the questions actually that came in the Q&A about weather and why other models don't include weather and why it's been sort of neglected in other models. Can you speak to that?
Well, when you throw in a linear,
some answers. But.
Yeah, so when you're dealing with a lot of these variables, even mobility, you also need to understand the nature of transmission. So, you have lots of lag variables, and sometimes we have multiple lags going on in the weather modeling. We actually lag the weather over like a 14 to 21 day period, each with their own lag to the actual transmission day. And so it's more of a three-dimensional wave. And so if you look at Antonio Gasparini's work, it's very, very complicated. It was some of the most impressive modeling that I'd ever seen, but it's not easy to do it. And if you just tried to put a temperature in and try to model it as a linear term, you could see, because of that bimodal distribution that I showed you, that you lose the important richness of the seasonality of this virus across multiple different seasons. And so people have watched transmission over time. They saw the transmission in Brazil, they saw it in Florida and Texas and Arizona last year, and they said, oh, it's not a seasonal virus, when in fact what you have is a lot of forces pushing and pulling against each other. If Arizona got as cold as Alaska with a bunch of with the kind of density of people crowding indoors, that would have a lot of forces pulling in the same direction, right? For significant transmission. And that's why those industrial cities of the Northeast and the upper Midwest have always captured our attention, because in wintertime, they have the holiday gatherings, they're crowded, and it's cold. And so you have forces that come together. In summertime, you may have a little less permissive environment for transmission compared to winter, but you have so much travel going on in the state of Florida. And then in very high heat and humidity, everyone drives indoors into those air-conditioned environments. And so you have to think about, in every step, in every moment in time, a bunch of pushing and pulling forces. And I think when we start to get into those multifactorial things, people have a hard time grasping that the seasonal effect can be maintained throughout, but that doesn't mean there won't be transmission in the summer. And that doesn't mean that after July 4th, when we declared that we had beaten this thing and everyone took their masks off and went to a big party, we saw RTs that actually jumped to 7, 8. Those 2 to 3 weeks after July 4th were some of the highest transmission rates we've seen in the entire pandemic. Had nothing to do with the weather, had to do with the way we gathered.
I'm a psychologist, so I'm very excited to hear the emphasis on behavior as much as the number on the weather dial.
I think behavior is the single most important factor. That, transmissibility and behavior, the transmissibility of the virus and behavior are probably the two most important factors, and then weather is probably the third.
Interesting. Well, I have a question here about testing. So a question that come in is about a key component of tracking is the availability of inexpensive rapid tests for COVID. These are widely available in Europe. Do you agree that these would be helpful, and how soon will we see these tests available?
Well, we have them in our region. We've done over 600,000 of those rapid tests in the schools. And in fact, this to me, I think, look, I've had a chance to work across the Trump administration and the Biden administration. And, ironically, in some ways I felt like the Trump administration was more prepared. The people who were working, Admiral Gerard, Debbie Birx, obviously they had Operation Warp Speed going, but they also, when we started our program of testing in January, I mean, they couldn't move tests quicker off the docks. We were literally like, I was getting calls from supply chain over at CHOP because just trucks were showing up at CHOP with tests. They were just pushing them out. I think when Biden took over, there was a sense that transmission was declining, and they could start to kind of go into more of an assessment phase for the next pandemic. And a lot of the operational people left. Birx left, Gerard left. Things went back over to the CDC, and they didn't renew Abbott contracts. So Abbott stopped making these tests. And the Binax now has probably been the best and most reliable test of the rapid test. That's the one you can buy at CVS now, although it's too expensive. And so we were caught flat-footed this summer without the test, but our team continued to look for them, and we quietly kind of moved another 750,000 tests out of North Dakota through what's called the supply exchange at HHS. But we positioned enough tests here to provide ample testing for all the schools who wanted to do it, to help them push through the winter this year and to keep kids in school, because we no longer see school policy as classroom closures. And we no longer see school policy as mandatory quarantine, and that's allowing us to launch the Test to Stay program. So I think that whoever asked the question, that is, to me, what our country really needed. That article that David Leonhardt wrote about rapid testing was spot on. We needed to flood the market with rapid tests. And even in their school policy, the administration chose to invest in pool testing, which to me was a failed strategy from the outset. Those of us who had been doing testing in schools in large volumes knew that a lot of families were not going to consent their kids for testing. You needed to have testing strategies for those willing to be tested and for some of your extracurriculars. But pool testing only is valuable if you can test everyone in a classroom and get a rapid result. And outside of an independent school, which can require testing of all their students, that wasn't the case in most schools. And so those programs got a lot of funding over the summer, but there's not been a lot of uptake in these pool testing programs. And the testing programs that have really launched are the ones that are using rapid tests, because they're easy for not just a school nurse, but an office administrator to quickly do a test on a kid who shows up at the office, to really quickly triage the situation, or to have kids returning from quarantine and just get a rapid test and go back into the classroom.
Kind of following on this same thread, I have a question here from a fellow psychologist and a fellow mom to kids in the Philadelphia School District. So we both, I think, would like to thank you for the important work in so many areas of children's health that's very directly relevant to our own personal lives as well as our professional interests. And she notes that if you saw the front page of the Inquirer yesterday, you probably know that there are 20 to 30 schools in the district without a nurse in the building. Nurses are expected to do both their regular and a whole host of important COVID-related responsibilities. Kids are now more at risk from non-COVID medical emergencies and are missing more school than they have to when they have a runny nose, because no one can test them for COVID. So in her non-day job, she's a school district of Philadelphia parent, just like I am, and she's very actively been advocating for solutions, particularly to this problem, among many others. Do you have any evidence-based or other suggestions that she could take to the district, school leadership, or local representatives to address this issue? And thank you again.
So again, in everything is local, right? And we do a fair amount of advising for the school district of Philadelphia as well. We set up the program and we talk about different options of how they can use the tests. I mean, if the school district of Philadelphia had the resources, and that's the big caveat, meaning they had the staff to do this, they could have tested everyone. I mean, we have school districts trying to do that, although even the largest school districts are really having a hard time testing all students. But the school district, they have hired vendors, but the whole vendor selection process has been delayed. And so they don't have boots on the ground. And so I can provide them tens of thousands of tests a week, but if there's no one to do the tests, you can't do anything. Now, that is changing. It's taking time, but I know there are new vendors coming on in November. We're trying to alleviate the responsibility of the nurses, or trying to help them alleviate the responsibility of the nurses to actually be the ones that have to deliver the test. And so, they have plenty of funding. It's a matter of finding available people who can actually do the tests and actually distributing them out to the 200 plus buildings that are in the school district of Philadelphia, so that we can do this equitably. Because I fear that the schools that are doing it well right now are the ones that are higher SES, or in communities with less disadvantage. And so what you have is a high rates of quarantine going on in communities that can least afford to have that. Hence the pivot to a Test to Stay program with new vendors coming in, recognizing that our goal is to try to equip these schools with having someone on site every day, to be able to not just test the teachers once or twice a week, but to increase the footprint of testing for the kids, particularly in relationship to these exposures in quarantine, so that they don't all have to go out every time there's a kid who tests positive in the school. It's not an easy answer. I mean, because, we can advise them on how to use the tests, but these are the implementation issues that I think in some ways, I could look at this nationally and say, you know, when they designed a testing program, it took us 9 months to build a testing program that's now averaging 30 to 40,000 tests a week. And even within that, there are some schools doing it really well and others that are still trying to get their feet under them. And the school district of Philadelphia has 100,000 kids. I mean, it's a large venture. They're getting better at it, but it's taking time.
Go ahead, Lois. Yeah, please.
That reminds me of the burden of mental illness, which depressive disorders and anxiety seem to be increasing both globally and locally. And are those data being captured at all?
Oh, absolutely.
In
Yeah,
your model, or?
not in a model because that we're modeling transmission, but they're captured in the way we advise folks. I mean, we do a lot of screening in our own practices. We have, we have well over 600,000 kids in our primary care practices at CHOP who are routinely screened during their well visits. Yes, we've seen increasing rates of anxiety and depression. It predates the pandemic, but has been exacerbated by the pandemic. I mean, the social isolation of the pandemic has definitely contributed to what's going on. With regards to anxiety and depression. But social media has as well, and a lot of the issues that predated the pandemic and the divisions in our society that helped also, create some of this growing risk for anxiety and depression predated it. I think right now that weighs heavily because you have to start pushing back against that. And so I find myself often now on the minority saying, as people sort of try to extend restrictions, let's say on extracurricular sports, my argument is, no, you need to just provide the test, try to do it as safely as possible, but get kids back on the field. You need to get kids back in the choir. We're working with the Philadelphia Boys and Girls Choir. We're working with the drama programs. We have to start getting kids back to their normal lives because that's the only way I can respond to that. Now, there's a larger issue there about school-based mental health programs. It's not just that the demand for services has increased, but we've also lost access to services. We had a lot of mental health professionals leave the field. Many still are not seeing people in their offices. This was on top historically that of a paucity of providers who were willing to see children on the weekends or at night because they'd have to leave school. And so what we really need now is our team believes, and our behavioral health team at PolicyLab, is a real investment in school-based mental health, briefer interventions, working with psychologists, group interventions. There's some really interesting evidence-based programs coming out on briefer interventions that can touch a larger group of kids. But we really need to start making the investments about bridging those ties again. And there's a long, complicated history in Philadelphia as to school-based mental health and where those programs have failed over time that need to be addressed.
Yeah, truly a global issue as well. I heard Dr. Tedros yesterday, who was on a program of the University of Michigan, and he talked about the issues of the solutions are vaccination, of course, for the future, but also this resilience in our public health infrastructure. And that mental health is just one indicator of the lack of resilience we have and we're losing in our public health infrastructure. And then he also talked about the capacity of course, of financing and in information systems, that it'll take those sort of 3 buckets of things to get this under control globally.
Absolutely.
So speaking of vaccination, I have a question about vaccination here. If the risk of hospitalization and death for young children is so low, why is it so important to vaccinate young children?
Well, it is low, but we've lost nearly 700 children to coronavirus since the beginning of the pandemic. That's below what we normally lose to flu and from other serious illnesses for which we routinely vaccinate. Just, to me, it may be low, but, there's a lot of deaths and there's well over, I think we're probably over 20,000 hospitalizations at this point. in kids. Don't quote me on the number of hospitalizations. That one's not ready at the end of my mind. It might actually be higher than that. But so to me, there's a fair amount of illness in kids for which vaccination would be important. We're just beginning to identify associations with other chronic conditions. There's an emerging association with diabetes. In kids, they've seen a significant rise in the incidence of type 1 diabetes. We've seen some severe outcomes with explosive diabetes among some of the kids who've been really sick at CHOP. There have been other autoimmune effects. And so there's going to be a long research now into, some people call it long COVID in kids. I'm thinking it more as the chronic manifestations of COVID and in terms of future morbidity. But most importantly is collectively, I think if we're truly to get our kids back to normal and stop the disruptions in schools and to reduce the impacts of coronavirus in the lives of families, the kids need to be part of the response. And I think the risk to kids has been far overstated. I know that the concern about myocardial inflammation was raised in the 12 to 18-year-olds with regards to COVID. And here's an example of what, is that when we look at the risk of vaccination, we often don't know what the counterfactual is in terms of the risk of disease. And so, for example, if you look at the Israeli data and you look at the data that's been reported out on myocardial inflammation, it's on the par of about 1 in 20,000, 1 in 25,000 with this mild myocardial inflammation that for us has only been a few kids at the hospital that responded to Motrin. And it was very brief. There have been no deaths associated with that. But there was a Big Ten study in Big Ten athletes last year. There was also a study of Israeli military recruits that demonstrated by actually studying all the basically adolescents and young adults in those studies who had COVID, that the risk of myocarditis was 2%, 1 in 50. And of clinical myocarditis, meaning with symptoms or, like really meaningful, was about 1 in 180 or 200. And to me, when you start to actually understand the subclinical effects of COVID illness, whether mild or severe, in its aggregate compared to the vaccine, it becomes a fairly easier decision as to why I vaccinated my own children and would quickly vaccinate younger children or my grandchildren if I'm lucky to have them someday.
Well, this is a question that's perhaps particularly appropriate given the season we're about to enter and the data we know about seasonality and behavior. So going back,
the number one intervention, I know the boosters are important for the vulnerable individuals for severe disease, but the number one thing that can really kind of take the wind out of sails this winter is vaccinating as many children as possible. When you look north to Canada has vaccination rates that are higher than us, and they're still having some flare-ups there. They had it in Calgary. They're starting to see numbers turn a little bit northward in Quebec again. They're at 75, 80%. We're seeing Vermont tested right now, and Vermont's our most highly vaccinated state. It's a little more rural, so they're more spaced out. It's suggesting that we need much higher rates of collective vaccination that includes our unvaccinated reservoirs, and kids are the largest unvaccinated reservoir at this point.
please, Lois, yes.
Yeah, another question. What you mentioned the variant that's in the UK, it was in the news today, is really responsible for a sudden surge there. So what do we know about that?
Remember what I said to you today, right? I'm sure that, if you're seeing something outcompete Delta, it's likely more transmissible. So it's rising. It's at about 8%. So it probably has some components to it, and it's in its structure that makes it a little bit more transmissible. But again, everything that's happening in England is exactly what I would have predicted regardless of the variant. What's happening in England? The days are getting shorter, colder, wetter, right?
Right. People
are moving indoors. And they never talk about that. And they ended their masking policy completely.
Yeah.
So it's not to say that they should institute a masking policy, but sometimes we give too much credit to the virus when it's really explainable by our behavior. So to me, it's obviously a combination of factors, but I would say unless I see a strain that truly escapes the vaccine with regards to severe disease, I think that's the bottom line. I don't think these individual variants yet have demonstrated that they're of sufficient magnitude, including Delta, to really alter the fundamental dynamics of how we're going to bring this to an end.
There's a question here about masking. Do you provide, or can you provide written guidelines on masking in schools?
What do you mean? What do you mean by that?
I'm actually not quite clear the question. I think it's asking about, has CHOP PolicyLab provided any written guidelines on masking in schools, or you?
Yeah, go visit our guidelines. What we talk about is we actually prepared parents around mask optional policies and how schools were going to be making decisions on those this year. And we thought that the most important thing was to recognize that this year, whether it happened in September or in January, and I think the state's decision to require masks indoors, which I think recognizing the some of the arguments around the younger kids made some sense, and we were in substantial transmission anyway, was fine. But I think what we tried to say in our guidance this year is that this will be a year, prepare yourselves, where government is going to be less likely to be the ones requiring things. They may make recommendations, but eventually it's going to turn over to local school districts and ultimately back to parents. And so if you are a parent of a child, how should I make a decision as parent of when I might want my kids to alter their behavior, when I might want to send my kids to school with a mask on? And so our policy this year was really focused on how we communicate with parents about the decisions you make in your own life around your gatherings and how to mask and what your own appetite for risk is, all of the above. And so you should go visit those recommendations. Not too many people talk about them. The CDC was going in that direction until they weren't, right? The AP came out pretty strong in favor of just, we're going to mask. But I worry that not messaging endpoints and not understanding the complexity of that issue is what's contributing to a lot of the divisiveness right now. I think our guidelines provide a little bit more of a practical approach to understanding when masks can be helpful or not, and why schools might choose to go to mask optional policies at certain points in the pandemic, and certainly over time as we move closer to the end of this.
And thinking about the way people gather and how that can lead to an increase in spreading, this is another question. Would you say that going into the future, it could become a possibility that of limiting the amount of people in a gathering, perhaps
No.
going a repeated way?
No, I think it's really important. I think one of the most important things for us, but hold on one second. I'm sorry, but I have been, in my work with Dr. Birx, in my work with Dr. Birx,
He needs help.
Can you hold on one second? I'll be right back.
I'll take this opportunity to note that there will be a link to this recorded lecture available. So I know that was a question that a few of you asked. So there will be.
So anyway, so my answer to your question is, one of the things we worked with Dr. Birx on was trying to understand the limitations of when government should intervene from the public health perspective. It's around that applied public health model that we've talked about. And I think it's really important that we understand there's a basic principle that of limited intervention in the lives of families that has actually been, I think, that really underpins a lot of what we do in America. And so anytime we make a decision to require things, whether it's occupancy restrictions or whether it's masks in schools, it needs to be understood that that is not a normal thing, right? And this is this is where I sort of have understood the policy folks to be. And so when you're making a recommendation, whether it's SecBeam's order to require masking in school, she did that because she weighed in, understanding that that was a big move. That's not a move that's made lightly, but felt that in the interest of safety, with vaccinations not yet rolled out the shelf for large groups of the population and rising transmission in the state, we were not yet at a point in the pandemic to completely absolve our communities locally of all masking. And I think Florida really bore that out this summer. And we could least afford that. We weren't in the warm state of Florida that's not just benefiting from susceptibles being removed, but also being in a temperate area with less travel right now. We're in Pennsylvania, it's going to get cold here. And so she weighed that. But I could tell you that each of their decisions, my experience working with each of these public officials, is those decisions are not made lightly. And the moment they can retreat from those decisions back to individual freedom, they're going to do that. And so that's why I think mask optional policies are coming sooner than people realize. And everything we're trying to do is actually trying to move to a step down as we get closer to the end, because we're never going to eliminate this virus. We can only hope to manage transmission and make choices in our life about how much risk we're willing to take for us and our children. But we're not going to eliminate this virus. It's going to become an endemic virus. And so I think the future is going to be one without restrictions and much more of a tolerance to these ups and downs that hopefully are not of the significant magnitude that we've seen over the last year and a half.
We do require vaccinations
Absolutely.
for
Absolutely. Because it is
children to enter schools. So where do you draw the line here?
Well, to me, that is the number one most effective intervention. And so we've been very supportive of vaccination strategy, because that removes the need to do all these other things in terms of allowing for freedom of movement. And, it's, if I were to go back to my own, sort of reading, I'll leave this with you since we're in a more intimate conversation. One of the best books I've ever read about American culture is Freedom. By Jonathan Franzen, for those of you who have read Jonathan Franzen. The principle of that book is about this value of American freedom and how dear it is to every individual. The problem is everyone's individual freedom encroaches on everyone else's individual freedom. And so everything about political governance is about where to draw the line of where you have to regulate that, because it can't completely be unregulated. And I think that, vaccination strategy has been one of recognizing the relative value of using that as a way to allow everyone else to share in that freedom. And so therefore, I in that particular area, I lend myself to vaccination mandates. I'm not saying for COVID vaccination mandates. I think there's a debate that we're still not ready to have yet on the kids, but certainly at the employer level, we're ready to have. But I think there's still some questions in COVID research that I think we need to recognize the role of natural immunity in terms of protection against severe disease and reinfection. And I think that needs to play out, because what we really want is an immunity mandate right now. And if we find that natural immunity is far inferior to vaccination, then that would favor a vaccination mandate. But I'm not sure that the data has fully been analyzed and completed on that end right now. And so that to me makes me a little bit more cautious and has my team not talking as much about vaccination mandates right now.
Mm-hmm.
Well, I'm going to wrap us up with one last question that I think is a nice final item to reflect on. And it's a question that asks, how has the pandemic changed you and your practice?
Well, I talked about the applied public health model. I think I recognize the limitations of science sometimes, and I don't see that as bad per se. I think people lament that science doesn't drive everybody. We all know that science comes with a fair amount of uncertainty, so you should never be so sure of yourself, right? And sometimes science is a little too sure of itself. And I think that's when we make mistakes. And so I've learned to be a little bit of being informed by the science, but also have a healthy skepticism about it, just like we're all sort of trained to do around uncertainty, and to remember that principle. With my patients, it's to recognize that different points of view, to not dismiss different points of view, but try to help people understand, to distill real information from misinformation, but to sort of to still maintain empathy, because in empathy comes understanding. and the ability to persuade. So I know there's been some vaccine hesitant folks in my own practice or parents who will listen to me because they know I'm not judging their hesitancy or some of their crazy theories. But then I'll tell them what I saw and it changes their mind because I didn't judge them, right? And I just tried to help them see it from my perspective.
Well, I can't imagine a better final point to.
Yes, that's wonderful.
That's, I think, an important perspective. Thank you so much, Dr. Rubin, for sharing.
Everyone, thank you for having me. And good luck, everyone. Stay safe out there this winter. All right.
Absolutely.
Thank you.
Thank you, everyone.
And
the link will be posted to the website, so you'll all be able to access this information to review. And certainly do go visit CHOP PolicyLab for more information.
Thank you.
Thanks, everyone. Good
Great
night.
job. Thank you.